Dr. Delva will continue the conversation.
Good morning again. I turned myself up.
You may need to turn off a few mics so that his mic will become active.
There. Good morning again. As a social worker, having had the opportunity to be a member of this committee was truly an honor, and all of us have had the experience that has been shared that this report, this work is so timely because people are doing these things that we're describing in terms of changing the learning experiences of our students, in terms of working more integrally connected with communities. But they're doing it from our sense very in silos, and we hope that this report will help bring these groups more closely together, will provide some fuel to the fire, and will help it take forward. So the committee felt very strongly that it was important to have a community domain, one of the pillars of the framework, and that essentially, the idea comes from our own experiences, as it was described earlier, in the literature that has shown that individuals and families are part of a larger context, of a larger network. These could be bounded by geographical nature, such as a county, a city, a barrio, a village. Or it could be actually non-geographically, but through different identities and intersectionalities of various identities, different population groups, where the inequities and the health disparities are experienced on a day-to-day basis. So we thought that it was important to take as we conceptualize this idea of training our next cohorts of health professionals to integrate the community, but beyond what a lot of us are doing. And there are many health professionals that have experiences with the community, and social work is certainly one of those. About 1/4 to 1/3 of a social work student's education, whether it's an undergraduate or graduate education, involves doing a field internship. That's 16 to 20 hours a week for 2 years, for example, for graduate students in a community. So even in social work, where we have this type of embeddedness in a community, there still is insufficient because those relationships don't tend to be equal, that we don't share equal power. So one of that you'll see in the report is that we're calling for an education of health professionals that involves the communities through a reciprocal commitment, through identifying community priorities and community engagement. Just very quickly, by reciprocal commitment, we mean not just having an understanding of the needs of the community, but being more embedded, because that will give the health professionals a better understanding of the assets, of the formal and informal resources, of the networks that exist, which in turn, and it sort of makes sense, it would help then when we do interventions, by having the community members as partners, the interventions are more likely to be applied, they're more likely to be applied sooner and potentially more effectively. We also talked about the importance of identifying community priorities from the community perspectives, and that involves doing health impact assessments. And I'm a substance abuse researcher, and I remember about a decade ago, this was very shocking to many of us. We were celebrating in the state of Michigan the very steep decline in the prevalence of cigarette smoking in the state. We're all happy. Separately, we did a big study in an area in the city of Detroit where health disparities are just tremendous. The poverty rate is very high, unemployment is high, school dropout is high, and it was a study, actually an oral health project, but we measure, therefore, substance use, especially smoking, and about half, we estimated about half of the population in that large area were smokers, women and men, almost no difference, which was completely different from the rate of smoking in the state of Michigan, much, much higher. So that highlights what we're calling about. If we had this closer commitment to a partnership with communities, we would be able to understand that some policies are not impacting the populations, some of them that have the greatest needs in the ways we would like to. So again, the idea of including communities as partners, as more equal partners, is one of the calls of the committee. And of course, as part of that connection, we talked about a community engagement where we, based on the literature and our own experiences, we think that it's important to make a concerted effort to recruit populations from these diverse communities into the workforce, to be the next workforce, because a large number of individuals from the communities are likely to go back and practice in their communities, or keep a foot in there, or a hearing about what's going on, and might be more likely to have a positive impact in the communities that they're from there. So the idea is that we'd like to propose that the community, that we work with communities as an equal partner in teaching health professionals, faculty, and students about their experiences, so that community members can help identify priorities. It's not something that's solely imposed from outside. We're not saying this could be easy. We're saying this is aspirational, and that we anticipate having better outcomes. And we have examples that we might mention later about the lead problem in the city of Flint as an example. So we believe that through shifts in power from health professionals to community members and organizations, it will also increase the community's share of their responsibilities in this partnership to affect positive change. With that in mind, the recommendation is that there remains a need for health professionals, schools, and organizations to recruit, admit, and retain candidates that have been negatively affected by the social determinants of health. The recruitment would be ideally drawn from the local community and would represent the population to be served. In response to this need for recruitment and retention, the committee makes the following recommendation that you see in the slide that I'm not going to read to you, but that it's fairly well described in the report. The enabling action for this recommendation is that health professional education and training institutions should support pipelines to higher education in the health professions in underserved communities, thus expanding the pool of viable candidates who have themselves been negatively affected by the social determinants of health. Thank you.
Thank you very much. And now Dr. James will continue the conversation around the framework and the recommendations.